so much for coming to our first ever pro-choice check-in. I'm so delighted to see so many familiar names in the chat. My name is Rebecca Hart-Holder, and I am the Executive Director of NARAL Pro-Choice Massachusetts. And we are the Commonwealth's leading grassroots pro-choice advocacy organization. And I'm so thankful to have all of you here with us for the next hour. I've got my coffee. I hope you have yours too. This is going to be a really interesting conversation, and I hope that you will enjoy it. We are going to do just a couple of quick housekeeping things. I want to just let everybody know, like you, I'm working from home and I'm splitting childcare duties with my wife. So at some point, you might see a 5-year-old run in feeling irritated that I have taken over her room for this hour. And I know you'll all go with the flow on that. I also know lots of folks are in the same position. So thank you for that. So we created this conversation series as a way to stay connected with our supporters and activists as we continue to do our part to keep people safe from the COVID-19 pandemic. And it's really our hope that these check-ins are going to be informative, engaging, and keep you inspired to advocate for reproductive freedom. We're going to cover all kinds of topics like birth control access, the continuing impact of COVID-19 on abortion access, Supreme Court cases, and many more things. We're really open to discussion ideas, so please feel free to send them to us. We would love to hear what sounds interesting to you. And really, most importantly, we hope that this provides a much needed sense of community and escape during these difficult times. And this is our first one, so please feel free to send us feedback if you think we can do anything better. We just want to get better with everything that we do, so don't hesitate to send that feedback. A couple quick tech housekeeping notes, and then we'll dive into our conversation. So as you can see, we are using webinar mode with Zoom, and that means that video and audio feeds are muted for the folks who are joining the call to listen in. We've done this because of a proliferation of Zoom bombing, which actually quite a few NARAL affiliates across the country have been subjected to. We'd much rather see all of your faces on video and have a more interactive conversation. But we are working hard to in lieu of that, try to still make this conversation feel interactive. So Kate Freilich is working behind the scenes to make the experience feel more interactive. So to the right of your screen, you'll see a chat icon, which a bunch of you are already using. If you have any technical issues, use the chat box to let us know, and we will do our best to assist you. And in the middle of the screen towards the bottom, you'll see a question and answer icon. If at any point you have a question for our special guest, you can submit it there. We'll have a Q&A period at the end. But you can feel free to send them throughout the conversation. And again, I appreciate your understanding that we're not seeing everyone's faces and hearing your audio right now, but I'd love to be at a place in a couple of weeks where we can do that. The last thing before we get started is that I want to remind you to follow us on social media. You can find links on Facebook, Twitter, and Instagram in the chat box, and that's the best way to find out what future events are coming up, about upcoming check-ins, and other updates and announcements about repro freedom in Massachusetts. And at the very end of the call, we'll talk about some other ways that you can stay involved. So with that behind us, let's kick it off. So I think we all know that the COVID-19 pandemic has exacerbated existing barriers to healthcare, including abortion care. Massachusetts was the first state in the nation to declare that abortion was not elective surgery and therefore did not fall under the elective surgery ban that Governor Baker announced a few weeks ago. And NARAL Massachusetts really sprang into action when he announced that ban and before he had defined the contours of the ban to make sure that the administration knew how important it was to define abortion as essential surgery, because we feared that anti-choice politicians across the country would use the crisis to further a really radical anti-choice agenda. And unfortunately, we were right that the pandemic would be exploited to try to ban abortion care. To date, 6 states have attempted to restrict access to abortion as part of their response to the outbreak. And the abortion ban in Texas will likely be heard at the Supreme Court in a few weeks. And, I think we're all very afraid that it could be a mechanism for the court to further restrict access, and that, it's something that it will be difficult to come back from. And we feel deeply that at this critical juncture where our healthcare system is under such incredible strain, it's the medical community that we should be listening to about how best to respond to the COVID-19 crisis and keep people safe, and not politicians who have a radical agenda. So I'm delighted to have Dr. Cheryl Hamlin here today to talk to us about the ways in which COVID-19 has impacted abortion care and reproductive health care generally, as well as her experiences as a provider both in Massachusetts and in southern states. Dr. Hamlin is an OBGYN with more than 2 decades of experience providing the full spectrum of reproductive health care to patients. And she practices here in the Boston area and also in Mississippi, where she works at the state's last remaining abortion clinic. She also was recently licensed to practice in Alabama. And in both Massachusetts and Mississippi, I think she has a really unique perspective on the barriers to care and how anti-choice laws negatively impact patients. And I think, like many of us, myself included, the 2016 presidential election really spurred her to become more active on the electoral and advocacy side for reproductive freedom and really speak out. So with that, I'm gonna start the conversation and really thank you, Dr. Hamlin, for taking time out of your schedule to talk to us. We really appreciate it. And thank you for being our first guinea pig. We appreciate that too.
Well, thanks for inviting me, and hopefully it'll go well.
It will. It definitely will. So, we don't often hear from providers who can talk about the difficulties associated with providing care during a pandemic, as well as the difficulties of providing care in a state that has, a real kind of anti-choice bent with anti-choice ideologies and policies. But I want to kick off our conversation talking about your work in Massachusetts. And I'm just kind of curious about your background and how you got involved with, how you decided to be an OBGYN and then how you got involved with providing abortion care.
OBGYN, I just liked delivering babies and I liked women's health. So it wasn't really related to, abortion care initially. But I trained at Boston Medical Center and got a good background. And the chairman, Dr. Edelin at the time, was very much an advocate for access to reproductive rights, especially to minority women. So that was sort of my background going into practice, and always provided the full range of care to my patients, and sort of naively, people have heard me say this before, sort of naively thought that, what happens is that women come and they ask their gynecologist that they want an abortion, and they schedule it and it gets done in a hospital without protesters, and the insurance pays for it. And I kind of thought that's just the way things went. And it really was the election that made me sort of realize, oh my God, this could go away. This isn't something to take for granted. And so I decided to be a little bit more proactive locally, and improve my skills and start working in an outpatient setting. But it became apparent that if I really wanted to take the next step, I needed to leave the state, and just through some connections, was connected with the clinic in Mississippi, and it's just, it was a perfect fit for me. I've really enjoyed going there, and
And how did you kind of come to Mississippi in the first place? Like, what was it that drew you there?
I had a midwife friend who enjoyed going to Mississippi and sort of said I should go there anyway. And then through introductions, I was introduced to the medical director there, kind of separately. And I thought, well, 2 people are trying to drag me down there, so why don't I go check it out? And everything fell into place.
And before the pandemic, how often were you going down to Mississippi to provide care?
So kind of once a month. It's not, so like for 4 days at a time. It's not quite that often, but like last year I went like 9 times.
Okay, great. So I wanted just for this group to read just kind of recite the list of barriers in Mississippi, and then kind of give you an opportunity to talk about what it's actually like to practice in the confines of those barriers. So Jackson Women's Health Organization is the sole clinic in Mississippi. Mississippi has what's called a trigger ban, so that if Roe is ever overturned, instantaneously abortion care will be outlawed in Mississippi. They also have a biased counseling requirement, and that counseling has to occur 24 hours before the procedure, but it's a 2-trip requirement because it has to occur in person. So the burden on the patient is pretty high. There's also a mandatory ultrasound law in Mississippi, and providers have to give the option to view the ultrasound to patients. There's parental consent. There is and people on this call, especially from Massachusetts, have heard us talk about parental consent a lot. There is a 20-week ban in Mississippi. You cannot provide telemedicine abortion in Mississippi, and there are also really onerous, what are called TRAP laws, or targeted regulation of abortion providers. So that is kind of laws that talk about how the clinic has to be configured, what it has to look like. They're extremely burdensome, and they don't comport with best medical practice. They're really just laws designed to be expensive and make it too hard for clinics to operate. So that's the kind of the legal outline, but I'd love to hear kind of, as a provider in Mississippi, how do those barriers impact your ability to provide care?
Yeah, I mean, I think the obvious onerous barrier is the 2-trip, requirement. So yes, they have to be consented at least 24 hours in advance, and it has to be in person. And because it is the only clinic for, many miles, I mean, we get people from all over the state as well as Tennessee and Louisiana. And so people do drive hours sometimes to get there, and then to have to either stay in a hotel or drive back home and come back again. I mean, obviously that's huge. And I think, it's a relatively common thing where someone will come in one day and and then they have to decide, well, now they've taken a day off of work today, so when can they get another day off of work? Oh, they could do it next Friday, but we're not doing procedures next Friday, so then it ends up being in 2 weeks, and it definitely does delay the time that they can actually get the procedure done.
I think that's a really important point, because it's not like you come in on a Monday and then you have the bias counseling, you give informed consent, and then 24 hours later on Tuesday you get the procedure, right? That right. It actually isn't just a 24-hour barrier, it's a much longer barrier.
Right, exactly.
Yeah. And have you found that I'm curious if you've had patients who it's just been too difficult for them to be able to come back to the clinic because of those barriers?
Oh yeah, for sure. I mean, again, the combination of having to take time off of work, and if they live far away, that means taking the whole day off. They're not just coming at lunchtime. The getting them money also, having to find money to pay for it, and now having to ask their boss without telling them why they're taking the day off, or finding childcare, or getting a ride. So yeah, I mean, certainly you do see people coming in several weeks later where they could have had a nice, early first trimester procedure, and now they're into their second trimester. And while I might not always know if someone never shows up again, but there have been people that said, yeah, I don't think I can come then. And it goes to say that we provide care certain days of the week. It's not 5 days of the week either. So sometimes there just isn't anybody there the day that they are able to show up.
Yeah. What about young people who have had to go before a judge to get a bypass? How have you seen all these barriers impact them in Mississippi?
Yeah, I mean, fortunately, I think there, you know, I've seen a lot of good family units. So I would say most of the minors I've seen have come with their mother. But we definitely do get some that have to do a judicial bypass. And again, just like in Massachusetts, it depends a little bit on where you live. Probably if you live in Jackson, it's a little bit easier to negotiate that. But if you're living in a rural community, which a good chunk of the state is, it's obviously going to be, quite a burden for them to figure out where they can go. And they don't have the luxury that the adolescents here have, where they can call Planned Parenthood, and Planned Parenthood will tell them, oh, you can, here's the numbers you have, and it's a lot more trying to kind of negotiate it on their own, and then having a couple hour drive to the nearest judge, and then having to start your 24-hour waiting period for the procedure and then come back for the procedure. So yeah, it's a huge deal when that happens.
Yeah. I mean, amazing to think how any young person would be able to navigate it, especially if they're not in a position where it isn't safe for them to talk to their families.
Right.
It feels
absolutely.
Impossible. Yeah.
Mm-hmm.
So I'd love to kind of compare and contrast your experience providing care in Massachusetts with Mississippi. How is it different? How is it easier in Massachusetts? We still have parental consent in Massachusetts. Just love to kind of hear you talk about the juxtaposition of those two things.
Yeah, I mean, the obvious thing is when you walk in the clinic and there's hordes of protesters. I mean, yeah, we get protesters in Massachusetts, but they're of a different breed. I mean, they really are loud and aggressive, and I've definitely had patients say that they were frightened, and they were frightened to go back to their car. So that's the first thing that hits you in the face when you go in, and then sort of have a security guard walk you in the back door in a way that I don't necessarily feel like I have to do here in Massachusetts.
And if for folks on the call, if you've never, I can't think of the name of, there's a great movie documentary that kind of talks about what protesters are like in the South. I'll think of it. But it's worth Googling Jackson Women's Health Organization and protesters to see just how aggressive they are. It's a very different climate in Massachusetts.
And they're so loud. I mean, just, and not, obviously not to make light of it, because it is very serious for the women that are trying to seek care, because they often are frightened. But when you're just kind of sitting there, sometimes it's almost enough to make you laugh. Like they have to play loud music, like rock music, like Pink Floyd, just to drown out the protesters who are just screaming horrible things.
Right.
So that the women don't have to listen to that while they're having their counseling session. I mean, it's just it's pretty dramatic.
Yeah.
And that wouldn't happen in Brooklyn, I don't think.
Right.
But then yes, I think, so like you said, the 24-hour waiting period, and just, sort of having people describe their, all the negotiations they have to make to get there. The thing that angers me is that I have to tell them it increases the risk of breast cancer, which is obviously false. I mean, I can say it's false, but I still have to say it. And I still, have women say, well, how much, like, this is really going to give me breast cancer if I do this? Like, no, it's not. I just have to tell you that. Like, well, why do you have to tell me that? Because it's the law that I have to tell you that. So, I mean, that really angers me, actually, because, you talk about conscious refusal. Well, why can't I refuse to say something that's a lie? So there's that. And then, and then I think because Mississippi did not expand Medicaid, I think it's very luxurious here, I realize, and not that it's perfect in Massachusetts by any means, but most of our patients have insurance. And they don't there. There is a whole lot of, and not even just to pay for abortions, but to pay for birth control. I mean, they really have to negotiate how they're going to fork out, money to pay, even if they can get it for $20 a month at the health center. It's still often more than they can afford. And I think a lot of the unplanned pregnancies are a result of them not being able to afford, they get started on a birth control and then they, came up short that month and didn't buy it. And that's often the reason that they're there.
Yeah, I mean, it speaks to how critically important Medicaid expansion is for states, and I think it's criminal that a lot of states haven't expanded to cover reproductive health care. So, generally speaking, how do barriers to reproductive health care affect your ability as a physician to care for your patients?
Yeah, I mean, I think it's just, again, I think, just all of the different logistics that you have to jump through, and then the other thing is that in Massachusetts, if it were to come up that, I don't think this, patient's appropriate for an outpatient procedure, for example, they have risk factors, you call the local hospital. There's 10 different hospitals around you could call, or take them to my institution, whatever, and do the procedure in the hospital. I mean, that's just not an option.
It's not possible.
And one young woman in particular, I felt like I couldn't safely perform the procedure because she needed anesthesia. We don't have anesthesia, and it's a big deal to get. I mean, the closest place to get, for real anesthesia would be like Atlanta, from Jackson. And so it's a big deal. It's not like, oh, well, okay, we'll call Beth Israel, the Brigham, whatever, it means going to another state.
Right. Which is insurmountable for many people.
Yeah, absolutely.
Yeah. So let's shift gears and start talking about the COVID-19 pandemic. Mm-hmm. And I'm curious, well, actually, have you been able to travel to Mississippi since this started?
No. The last time I was there was beginning of March. And so we weren't really in the throes of it.
Right.
And I'm actually, sadly, was supposed to be there this week. And it just seemed like that wasn't realistic. And so, and anyway, the restrictions now theoretically end April 27th.
Right. So you are providing care here in Massachusetts, and I'm curious about how the pandemic has affected, your patient care and some of the challenges or unexpected outcomes that you've seen.
Yeah, I mean, I think most of the hospitals I think most of the independent clinics are still functioning full service, which is the good news. And I think most of the hospitals locally, and I'm really speaking Boston vicinity, I'm not as familiar with the western part of the state, but I think most of the hospitals that have actual services are still running full service, but with tweaks. I mean, there's definitely the attempt to keep people out of the hospital as much as possible. And so, the NAF, the National Abortion Federation, recently, just I think in January, put out recommendations for expanding medical abortions to 11 weeks, which was just something that we're going to do anyway. But as it turns out, that's a great way to keep people out of the hospital. If now we can go to a later gestational age and provide medical abortions. I think there has been a push to doing more like actually in the office, like aspiration procedures without, even needing to be in an ambulatory setting. And so, people are doing that more to a greater gestational age. But I guess the most worrisome thing is that if someone actually is sick or testing positive, I think it's a struggle to know what to do with that. I mean, I think that the party line is wait 2 weeks, but obviously waiting 2 weeks can be a big deal. So I think people are making provisions so that if 2 weeks are going to get them beyond the legal limits or whatever, that it would be too much of a hardship for them to wait 2 weeks. I think there are provisions, but I would say most people would not, perform surgical procedures, certainly in someone that's currently positive or symptomatic.
Right, that makes sense. I'm curious as a provider. I mean, you're watching the news like all of us, and you're experiencing it as someone who flies to Mississippi to provide care. We've all seen Ohio, Texas, Mississippi kind of go out of their way to use COVID-19 as a way to restrict abortion care. And I have to say, I was particularly insulted by the governor of Mississippi, who said before they made any move to shut the state down, he said, "We're going to do everything in our power to protect people from the COVID-19 pandemic, and we're also going to try to outlaw abortion."
Yeah.
He was pretty naked in his political agenda, which I guess, thank you. But the argument that we've heard from the governor of Mississippi and from Texas is that providing abortion care wastes PPE, and that's why it should be banned. That's why abortion should be banned during the crisis. And I'd love to hear, from a physician, your take on that argument.
Well, I mean, what a joke. If Governor Reeves wanted to decrease wasting PPE, and then he would get rid of and increasing exposure, he would get rid of the 2-trip law, right? That's the first thing to do. Just make it a one day thing. Medical abortions do not require any more PPE than a prenatal visit. And so what's the alternative? They're going to get prenatal care.
And we have seen Texas, the law, a judge recently amended the law to allow medication abortion to go forward in Texas, which is good news for the people of Texas. Yeah.
And it's worth saying that in Mississippi, there are no restrictions. I mean, it hasn't changed. And he's talked a lot about it, but nothing's been passed. So while, again, the clinic is making all kinds of tweaks, they're still providing the full range of services.
For an aspiration abortion, and I'm a lawyer, so forgive me for this novice question, but what's the typical PPE you wear for an aspiration abortion?
Not that much different from so in an outpatient setting. I mean, you wear, minus COVID-19, you wear something to protect your eyes, and you wear gloves, pretty much, and some clothes that you can change easily if they get soiled. So that's pretty much it. And so add COVID-19 into it. Maybe you make sure you wear a mask. But if you were seeing a prenatal patient, you would wear a mask. You might not need eye protection, but you would wear a mask, and certainly if you had any concerns about their symptoms, you would wear eye protection and the whole thing. So it's really not that much different, even in a surgical procedure.
Yeah, I mean, it feels to me like it's a really specious argument. Like it's just it doesn't comport with reality.
No.
Yeah, that's
and then some percent. So let's just assume some women are not getting their procedure as a result of this. And so what's going to happen? One, they're either going to get prenatal care. Some small, but some real percentage of them will, seek emergency care for other reasons, whether it's because of a miscarriage or because of, hyperemesis, or they're vomiting so much they need, fluids. And it's not a terribly unusual thing that someone shows up to the ER for IV fluids because they can't keep food down. Or, God forbid, people start trying to induce their own abortion. And, now we go back to pro Roe v. Wade, and people are showing up to the emergency room because of complications of that. And that's certainly not helping anybody.
Right. And what have you been hearing from your colleagues in Mississippi who are providing care there? I mean, what are they telling you about how COVID-19 has exacerbated those barriers?
So some of the things they've had to do that all of us are doing, but when the barriers are already so high, it just makes it that much harder. So if the clinic's open 3 days, you try to get as many people in those 3 days, and obviously you can't have a waiting room full of women. So now you have to have people coming in at a less, sort of restricting how many people can actually be in the building at the same time, and lessening the amount of time that they're there. So I'm not sure how often they're actually turning people away because of that, but I mean, it's definitely completely turned the workflow upside down because of the changes that they need to make, and because it was already such a challenge to get everybody in. I mean, I can only imagine that, saying, well, we can only have this many people in the building at the same time is definitely going to impact the care they can provide.
Yeah. Have you heard anything about how the protesters are behaving? I know in North Carolina, the protesters have been not social distancing, or I should say have not been social distancing. And it has been the subject of some news reporting where the clinics have been, asking the state government to intercede. I'm curious if you've heard anything about those very aggressive protesters in Mississippi.
So from what I understand, they're still showing up, which by definition is not really what they're supposed to be doing.
Right.
They're making a show of, staying 6 feet apart and all of that, but they're still showing up in numbers.
Yeah. Ugh, as if the barriers aren't hard enough, that is right. Another kind of shocking one.
Yes.
So I'd love to kind of turn us to talk a little bit more about reproductive health care in general and the pandemic, and just want to kind of open it up by, asking what you think any patient seeking any kind of reproductive health care right now needs to know about accessing it.
Yeah. I do worry that people will get lost in the fray, even in a well-oiled system. So certainly just in terms of contraception, people are trying to do as much telemedicine as they can. And so I'm sure that there are going to be some people that, might have come in for their annual exam and discussed contraception at that visit. And, that's not happening. And probably people have heard that, or are concerned that abortion care is not available. And I would certainly want to, get out the message, yes, it is. But at the same time, there are delays. And so this is not the time to wait till the last minute, that there may be delays in getting in, whether it's because you're sick and you have to wait, or whether it's because again, they have to limit how many people are actually showing up to the clinic. So there may be more delays than people have, than there have been in the past.
Yeah.
We were talking about just things like, the whole discussion about what's non-essential care, tubal ligations. I guess it is elective, but I'm sure that there are going to be a few unplanned pregnancies as a result of people not getting their tubal ligation that they were expecting to get during this time frame,
Yeah.
or vasectomies as well. So, I'm sure there are going to be people that fall through the cracks. I think the services are out there, but they're a little bit harder to obtain.
And I'll just put a plug for NARAL's Guide to Abortion Care in Massachusetts. Kate Freilich has done a tremendous job updating that guide to reflect what the current changes to service provision are with the providers, both independent, Planned Parenthood, and hospital-based providers are. So just feel free to go to our website and or direct people there. That's an easy way for folks to kind of quickly scan and see how to access care. I have a curiosity about pregnancy and COVID-19, where people are carrying to term with a wanted pregnancy. What are you hearing about the risks to folks carrying a pregnancy to term? And also, I think we've heard in the news a lot, and I've had a couple friends, one who is actually due today, raise the question of what we've heard about in New York, where they were saying that you couldn't have a support person come in with you when you're in labor. So I'm just curious about that aspect of the pandemic as well.
Yeah. So, the expectation has always been, because with other viruses, in particular the, flu viruses and the previous coronaviruses, it did seem that pregnant women were, sicker for some of the physiologic changes in pregnancy. We haven't seen that so far with this. It's still kind of early in the scheme of things, so we maybe don't entirely know, but there have been a couple of studies, one in China and one, recently in New York, where it did seem that the risk of serious infection was not any higher in pregnant women. Um, and, so far it seems that there is not a vertical transmission, meaning from mother to baby through the placenta. So when they've screened babies, like right after birth, so they haven't had a chance to be infected by other ways, that they have been negative, and I'm not aware of any case reports of newborns becoming sick, either, you know, just because of the birth process or being in close proximity to a COVID positive mother. It doesn't seem to be in breast milk, so women can breastfeed, but obviously they're contagious. I mean, if they're COVID positive, but obviously they are contagious. So, there has to be a lot of good hygiene and, gloves and all of that, which is obviously incredibly hard. You just have a newborn and you have to practically sterilize yourself before you touch your baby. I mean, I can't even imagine. But so the good news is it doesn't seem like women are getting any sicker than anybody else, but they do occasionally get sick like everybody else. And there certainly have been women in the ICU as a result of it. But not necessarily a higher percentage than the general population.
Yeah.
But again, it's still early, and that could change. And we don't really know what's happening to women that have been infected early in pregnancy, what that's going to mean next fall. So far, we don't have any reason to believe that it has impact on the pregnancy, but we don't really know that yet either. So yeah, I mean, New York. So I mean, that the sad part about the whole COVID thing is that hospitals in general are not allowing visitors at all. And in general, labor and delivery is the one place where you can have one visitor.
Mm-hmm.
And New York did pass, or tried to say that, I guess I should say 3 hospitals tried to eliminate visitors altogether in labor and delivery. And labor and delivery is just a different world altogether. I mean, and there's lots of studies that show that women do better and have better outcomes, just even in things that seem like they would be unrelated, by having a supportive person with them. So I think they did pass a law that all the hospitals in New York had to allow visitors. But that said, it's hard because you still have to have some sort of screening process. So if the partner is symptomatic or has a reason to be tested, and now they're the PUI, person under investigation, or like, so that we say that if the partner's healthy and there's no reason to screen them or no reason to test them, but one person has to come, and one person, it doesn't have to be their partner, it could be their mother, but one person has to come and stay with them the whole time, and they can't leave and come back, and so they're kind of held hostage for their entire hospital stay. So it's definitely a challenge, I think, and I think it's a hard time to have a baby, but I think there's a lot of motivated people to make it as least bad as possible.
Yeah, I mean, I don't know, having gone through it, it's impossible to imagine not having that support person with you, because so hard to
absolutely
talk. It's yeah, but I was relieved to see that New York restricted that regulation, although I understood the rationale for putting it in place, but I felt like, and just to be clear, that's not happening in Massachusetts. People are still able to have a support person come in.
Yes.
Great. So I'm aware of the time. I'm going to ask you just 2 more questions, and then we're going to throw it open for the chat for people to ask questions. And I'll ask Kate to come back on and kind of help me with questions, because I've been paying attention to the conversation and not the chat. But, one of the things that we have seen, Boston, I know, shared some data about this, that, the COVID-19 pandemic is disproportionately impacting low-income communities and communities of color. And I'm curious, and I should say, we also know that barriers to abortion care do the same thing, right? We know that it disproportionately impacts low-income communities and communities of color. In particular, the Massachusetts parental consent law has that impact. There's important data from Planned Parenthood that was published in April of 2019 on just this fact. So I'm curious if that's something you've observed in your work, and what do you think the long-term issues will be with this?
Yeah, I mean, so far it's still anecdotal, and I think one of the issues is that when, collecting data, they haven't been necessarily collecting data on race or social economic background, but it does seem that it is higher in lower socioeconomic communities, and again, this is all conjecture. We don't entirely know, but it no doubt is related to more crowded living spaces, as well as many of those people are the ones that are, working in a grocery store or driving buses or whatever, have the kind of job where they have to get out and they're not being protected as well as they should. So I think it's definitely true, and it probably is maybe even more true than we currently realize.
Mm-hmm.
I think it's hard. I worry about what that means in terms of our approach to care, in terms of like who we test. And again, this is just me speaking right now. I'm not quoting anybody or, any studies, but I think, you have to be a little bit careful of testing the people appropriately to say, well, maybe you are at higher risk because you live in a crowded neighborhood and you live with, 10 other people, or you are at higher risk, but at the same time not stigmatizing people that, oh, we're going to screen you because or we're going to test you because you're Hispanic, and then all the things that goes along with that. So I think it's a fine line to walk, and I'm not sure we know exactly where that line is, and to be determined.
Yeah. Anything else I haven't asked that you want to make sure that folks hear about your practice, about providing care in Mississippi, about the COVID-19 pandemic, and also just a curiosity of mine of just how you're holding up as a healthcare provider at this time?
Fine. Thank you for asking. I'm not front line, and that, for the most part, the women I'm taking care of are healthy, and even the ones that have tested positive, they're generally healthy. So I haven't been, in the emergency room or in the, ICU, and I give them a lot of credit where that's what they're kind of doing all day long. I get a little bit of the happier side of it. Yeah, it is hard to walk into a patient's room, whether it's a prenatal visit or a laboring patient or a patient for an abortion procedure, to have suddenly now masks and gloves, and they don't even really know what you look like, and you don't know what they look like because they're wearing a mask. And I think it does make it harder to build those connections. So I think from my perspective, that's the hardest thing. It does just the nature of the kind of wall that we're necessarily building makes it harder to connect with the women that I'm supposed to be taking care of.
Yeah, that must be really difficult to have this shield, between you and them, when I think so much of reproductive health care, especially including abortion care, is about compassion and empathy and meeting people where they are. And so I can imagine that is a really difficult aspect of practicing right now.
Yeah, absolutely.
Well, I could keep asking you questions for a long time, but I'm going to pause. I'm going to ask Kate, who has been doing a huge amount of work behind the scenes, to help us with the questions. Thank you, Kate.
Hi, everyone. And just a reminder, you can put the questions in the Q&A box. We will try to get to as many as we can. I think we won't be able to get to all of them, but let's get started. Our first question is asking if there are fake women's health centers or crisis pregnancy centers in Mississippi, and do they play a significant role in providing false and misleading information?
Oh my God, yes. Yes, there are a lot. And, and there's certainly several, probably walking distance from the clinic. There is a movie, and I don't know if this is the one you were thinking of, but there's two movies that have the Jackson Women's Health in it. One is called Jackson, and one is, and the other one is Trapped.
Trapped.
And,
That's what I was thinking of.
That's what
yeah.
you're thinking
yeah.
of. Yeah. So the Jackson, the film it's called, is exactly that. It's a woman who gets kind of dissuaded away from the clinic. And I think it was filmed maybe 5 years ago, I don't know, and then ends up going to a crisis pregnancy center, and just sort of the balance back and forth between that. But yes, it is definitely a big player. Yeah.
And I think important to note that, I think it's easy to associate fake women's health centers with the South, when in fact in Massachusetts, for every one provider, we have 3 fake women's health centers.
Right.
Fake women's health centers are ubiquitous across the United States, and they are tenacious in their willingness to deceive women and spread misinformation and either delay or fully prevent people from accessing abortion care if that's their choice. Yeah. Kate, what's next?
Thanks. And I want to add in that Janet Singer just wrote to us that the movie 12th in Delaware also gives a good profile of these CPCs.
Oh,
so
okay.
A lot of us have time to watch movies right now. We have another question about the expansion of medication abortion, and if that is going to be happening more during this time. And then I'll also add telemedicine for abortion care.
Yeah, so like I said, it was a fairly recent change in the National Abortion Federation's guidelines, but it happened to just kind of predate this whole pandemic by a month or so. And, fortunately, it does, expand access. So I think that, we tend to be cautious, and I think that, people are saying, oh yeah, maybe we should do that. And like suddenly, like, yeah, starting today, let's do that, because that's, we can get that many more people in without being in an OR. And so, yeah.
And that's a change of a week, right? So the previous guidelines were up to 10 weeks, is that right?
Weeks, yeah.
And so that's a week, yeah.
And just for any medical people out there, that in order to make the failure rate consistent with the lower gestational age, you give 2 doses of the meso instead of 1.
Yep. And I know a lot of states across the country are looking at how to expand telemedicine using medication abortion. We're hopeful that Massachusetts will follow suit, because obviously that is an important distancing for people, right? It saves a visit to the healthcare providers. It's important right now.
Yeah, and I think, I think that could really make it a very easy, quick visit for, all the counseling could be done via telemedicine. So even in Massachusetts, where it could be a 1 visit thing, certainly the states that have, waiting periods, that's huge, because you can do that ahead of time. Yeah.
And just noting, I want to lift up in the chat a friend and colleague of mine, Jenny Sheehan, who has worked with NAF on these guidelines, is here, and she reminds me that NAF is also allowing no test medication abortions, right? So you don't have to go in and do the RH testing or the ultrasound, which is another way during the pandemic to decrease the office visits.
Yes. And also, that was also just as she was saying, that's sort of in the current 2020 guidelines, that you don't have to do RH testing, 8 weeks and below for any procedure, and recommending 10 weeks and even 11, I guess, for medical, which does potentially eliminate having to get any blood work at all. So it could be a very minimal visit. They walk, you do the counseling over the phone or whatever. They come in, pick up their pills, and then you follow up with them on the phone afterwards.
Yeah. I mean, a lot to be scared about in this pandemic, with the attempts to really outlaw abortion, period, in a lot of states. But if we are able to see an expansion of telemedicine in other states, I think that could potentially be a positive outcome, because it helps so many people get access to care earlier in pregnancy. And that, I'm trying to find the silver lining here, but that could be a good thing.
Absolutely, yeah.
Yeah. Kate, what's next? Oh, you're muted, Kate.
We have time for one, maybe two more questions. Another one that's come in is wondering about, in the states that have labeled abortion not essential during the crisis, is access to birth control, especially birth control that requires an office visit, also deemed not essential? And this question asker comments that her son is a general family practice doctor, and he's seeing a huge uptick in patients seeking birth control.
Yeah, I mean, I don't think anybody would, I don't know actually what's happening, say in Mississippi for someone who just wants birth control. I mean, I'm assuming they can, I mean, there were barriers to getting it before. I assume they're the same ones now, except that now it's probably harder to get an inpatient or, in-person visit. So if it's like an IUD or something like that, I imagine there are delays in getting that. But I haven't heard anybody try to claim that that's not essential, but I could be wrong about that.
Yeah, I mean, anecdotally, I haven't heard about getting the pill, for instance, being there being barriers to getting the pill.
Right.
I will say, little preview for this group. This week, we're going to be reminding folks that in Massachusetts, after the Trump administration tried to gut the contraceptive coverage mandate in the ACA, we helped pass a law called the Access Bill that says that we get, people in Massachusetts get copay-free contraceptive coverage, and also you can get a 12-month supply of your favored method of contraception. So I think this is a really good time to be looking at trying to get that 12-month supply. You don't need to go every month into the pharmacy to pick up your pill pack.
Right. Yeah.
So just a good reminder here. Kate, how about one more, and then we'll transition off.
Great. Some of these we've kind of answered. There's one more question kind of about the state of the legislature in Mississippi. As we know, state legislatures make a big difference in abortion access. Wondering, are there pro-choice voices in the legislature there?
Not a lot, because even some of the Democrats are not pro-choice. So I think it is a struggle of the lesser of evils. And, I can't say that I don't follow it close enough to name names, but, but when I'm there, I sort of talk about like, so who's, if there's an election coming up, like who, not that I would tell women who to vote for, but at least I have an idea to say, I do say, and I feel like that's my leverage. I do say, you know what, you guys vote. I can't. You guys have to vote. And if this is important to you, and sort of try to be informed enough that if someone wanted to know somebody's stance. But I think it is a struggle, because I think, like I say, not the Democrats aren't all that great either.
In my career, I've had the privilege of working all over the South on abortion access, and I will say it has changed some of my northern biases to really see how many people there are, advocates, people who show up at the clinics to counter protesters and support patients, even legislators in states like Alabama or Mississippi or Louisiana, who really stand up for choice. I mean, of course, it's a smaller number, but there are people doing absolutely amazing work in across the South, and I want to lift that up, including you, Cheryl. Yeah. I mean, I think I just think it's important to, legislators are very important to this fight. And I certainly think that, with the Trump administration, we've seen how critical state legislators are in pushing back. Mississippi is not going to have a pro-choice state house anytime soon.
No.
But there are people doing amazing work.
There are,
including you.
I don't want to diss them either. I did go to a little Planned Parenthood event in Jackson, and there were a lot of legislators that showed up. I was actually pretty impressed. So they're there.
Yeah, they're there.
Yeah.
Well, I want to be cognizant of the time. I'm so grateful for Dr. Hamlin for joining us today and for sharing your insights and speaking so candidly for us. You know, a tenet for me that is so incredibly important is that we have to hold on to what you know, healthcare providers say in this time. This is not a time for politicians to be intervening in healthcare and medical care. This is a time to be listening to the people who are actually providing the care, and it's just so great to hear from you, and I really appreciate it. I also want to thank everybody who joined us today for your great questions, your great participation. Anytime you debut something like this, you're always nervous about whether or not people will come to your party, but you all have completely surpassed our expectations. Thank you for your engagement. Thank you for being part of this. And I hope that you will join us next week for our check-in. So there's a link in the chat box so that you can see how to find out more about all the virtual events that we're doing as we really kind of transition to this digital world. You know, we're really cognizant of the fact that the COVID-19 pandemic has impacted all of us one way or another. But in order to do the work we do and continue to advocate for reproductive freedom in Massachusetts, we have really looked at how to transition to digital advocacy. So we're, you know, replacing legislator meetings with Zoom calls. We're replacing door knocking with text banks. We've created a new digital organizing fund to help us in this kind of new virtual world, to help candidates, to conduct email campaigns. And so, you know, if you feel inclined to spare $5 for that, we would always be appreciative of that. And next week, we will be back Tuesday at 2 p.m. We're going to be talking to Stephanie Toti. Stephanie argued the landmark U.S. Supreme Court case, Whole Women's Health versus Hellerstedt in 2015, and got an incredible win out of that case. And she is one of the lead lawyers challenging the Texas bans. So she'll be joining us to discuss that pending Supreme Court case that I think is coming up in the beginning of May. She'll also be talking with us about June B. Russo and kind of giving us the legal lay of the land and talking about the important role that Massachusetts has played in all of this. So you'll see information about that in the chat. You'll also get emails. You'll see it on our social media. And I really appreciate everybody for coming today. And we'll see you next week. Stay safe, stay healthy. Take care.
All right. Thanks.
Bye-bye.